speak today to all of you about a topic that is dear to my heart, and that is of colon cancer. My talk is going to take roughly 20 minutes, and I'll happy at the end to to answer questions and to interact with all of you. Um, I'm going to start my talk with a brief story. This is a patient who came to see me with a bleeding. He complained of abdominal pain, 52 years old. Um, Used to work in the medical field and semi-retired at a young age, with extensive history of cancer, colon cancer, ovarian cancer, breast cancer. Colonoscopy showed that he has a mass in the right part of the colon, the ascending colon. And this is on the left side, a CT scan. A CT scan is a computerized X-ray machine that helps us see better inside our bodies. So here on the right side, in October 2023, he had this mass measuring 12 centimeter. And this patient, because of his strong family history, was suspected that he had a genetic condition called Lynch syndrome, that it just predisposes patients to have malignancies. These patients respond excellent to a new immunotherapy treatment called ipilimumab and nivolumab. And he didn't get to go to surgery right away because this mass, it was close to some pelvic structures, the psoas muscle. And so the colorectal surgeon didn't consider surgery up front because of extensive disease. After 3 months of therapy, it seemed that the mass is the same size, 10 centimeter by 7 centimeter, maybe a couple of centimeters shrinking in size. But the amazing thing that happened here is that the patient had surgery and then no tumor was found in the pathology analysis after surgery. So this is how far we have come in our battle against colon cancer. Some patients responding really well to IV medicines and having the tumor destroyed. Not every patient, unfortunately, responds like that, and we will go into more detail. So what is the problem? The problem is that colon cancer is a very common malignancy. 150,000 new cases in 2024 in the US expected this year. The third most common cancer. It occurs at an older age, more than 65, 74 years of age. And another problem is that the incidence is rising in younger patients. Unfortunately, I have had patients 27 years old, 35, 37 years old. Used to be 5% of new cancer diagnosis of the colon were in less than 50 years of age patients, but now it's 12%. It has doubled the incidence. And not everybody gets screened. That's part of the problem as well. I wanted to emphasize with this talk about prevention. Super important. What is a screening test? It's a test that we do to detect cancer or a problem at a very early stage when the patient doesn't have any symptoms. Now, in colon cancer, what are the symptoms? It may be that the patient doesn't have any symptoms at all at the beginning, but eventually the patients will have abdominal pain, changes in the caliber of the stool, a stool that gets thinner and thinner by the week. That's a sign of colon cancer. Changes in bowel habits, abdominal pain, fatigue, weight loss. If you have any of these symptoms, if you or one of your family members have these symptoms, you need to go and seek immediate primary care attention. As this graph shows, the older than a patient is, the higher is the risk to get colorectal cancer, and for that matter, many other cancers, simply because our genes, they get lazier to repair itself. It's harder for our DNA to repair itself. When we are younger, 10, 20 years old, we are a reparation machine. But as we get older, it becomes harder and harder. It's higher in incidence in patients of African American descent, American Indian descent, Alaskan Native adults, and in patients such as in the person of our initial clinical history, somebody with a family history of colorectal malignancies or other types of cancers. Some patients with obesity, diabetes, long-term smoking, and unhealthy alcohol abuse are also at risk. This is important, this slide. A couple of years ago, 3 years ago, before 2022, it was okay to do screening colonoscopy starting at the age of 50, screening test. However, the problem is that we were seeing more and more young patients being diagnosed with colon cancer. Therefore, the guidelines changed. Now we recommend to screen patients starting at the age of 45. Everybody age 45 and above should have had already a colonoscopy or FIT test, a YX stool test, any test to screen for colorectal cancer. In adults 76 to 85, the official guidelines, the task force USPSTF recommends that it is on a selective cases, meaning depending on what's the life expectancy in a patient. If it's a patient who has other serious comorbidities, such as end-stage heart failure, end-stage cirrhosis, then probably doesn't make sense to screen. But my advice for primary care doctors is that when in doubt, we really need to keep screening the patients. And I say this because as a medical oncologist, unfortunately, many times I see patients who are more than 90 and they come with advanced cancer. And more than once, I have been told by them, no, because my primary said no more screening at the age of 80 something. And then here comes a patient who's 90, strong and healthy, that I'm treating for advanced cancer, and that could have been prevented. So it's on a case-by-case basis, but when in doubt, I'm more on the aggressive side. Just keep screening, because it's easy enough just to do a stool test. Now, some other patient populations we need to screen more, meaning not just based on age, but for example, if somebody whose mother died at the age of 40, and that patient died of colon cancer, I would recommend for that son or daughter to be screened at the age of 30, 10 years before the first-degree relative was diagnosed with cancer. Somebody who has, for example, inflammatory bowel disease, ulcerative colitis or Crohn's, those patients need to be screened as soon as they get the diagnosis, and the screening intervals are every 1 or 2 years. I remember a patient, he was very young, early 30s, inflammatory bowel disease, diagnosed with colon cancer. And some other patients who have multiple polyposis, meaning lots of benign polyps, but these might become malignant. What are the screen tests? There are two main subtypes. One is when you check the stool, and those are stool screen tests, and the other ones are the colonoscopy. And if you ask me, okay, doctor, what's the easy one to check? It's called a fecal occult YX test. It detects blood in the stool using a biochemical assay. Your primary care doctor gives you a card, you put the stool there, and you put some chemical droplets, and then it's going to show up whether there is blood or not. Every year, you need to do that. If that is positive, then you need to put a camera and look at the rectum and colon area to see if there is cancer there. Other test, fecal immunohistochemical test, is very similar, same the stool, is just using a different technique. You detect a blood using an antibody. So another type of protein, but it's also every year, and the collection is similar. You put stool there and then check for that. And then there's another test called a FIT DNA test. It not only looks for blood, but also looks for biomarkers by cancer cells from the lining of the colon into the stool. So it's another chemical test in which you collect the sample and you're able to see whether there is signs of cancer or not. Those are for people who want to improve the survival, decrease the risk of cancer showing up at an advanced stage, and who want to be on top of their health and pick up cancer soon. The other option is to do a colonoscopy. Colonoscopy is obviously invasive. A colonoscopy, you put a camera in a canal, rectum, look in the colon. We have an expert here, Dr. Herline, that will give you more details about that. But basically, you want to take a look to see if there is any cancer there and take out the polyp. And you do that every 10 years. Sigmoidoscopy is A shorter version of the colonoscopy, so to speak, sigmoidoscopy only takes a look at the left side of the colon, the rectum, and it's recommended to be done every 5 years. So you do either. This other test, it's a CT colonography. You take a picture, computerized picture of the belly, and it's done every 5 years. So you have to choose. Now, if you ask me which one I recommend, any of these is recommended. Particularly, I like the evidence more that is in favor of the FIT test, the one that is done, this FOBT or the FIT test once a year, because this one has shown to improve survival. And also, particularly, I like the colonoscopy because it's once and done. If you detect the cancer there, you take it out right away if it's small enough, but you know what it is. And it's also not as frequent, it's every 10 years. It's also considered the gold standard. There was a lot of controversy because there was a European trial that showed that it didn't improve survival, but that trial had some drawbacks. And basically, in my opinion, that trial, and in the opinion of many oncologists, the great majority of oncologists here in the US, is it had some methodological flaws. Therefore, we still recommend strongly colonoscopy or FIT testing. And this is a more detailed slide that talks about everything that I said, the FIT test, the YX tool test, colonoscopy, etc. Risks are low because, for example, perforation, which is like a feared complication, only occurs in 0.05% of patients undergoing a colonoscopy, and this number might even be lower now. Now, let's briefly talk about what are the colon cancer stages and the treatment. Stage 0 is when it's something that it's a cancer that it's something that is not invasive. It's the patient's never going to die from that by definition. Stage 1, when there is a cancer that is invasive and it's small, localized in an area, could be in a polyp, for example. Stage 2 is when the cancer is bigger and it has started to grow into this layer, the muscular layer of the colon. And stage 3, it's when it's a big cancer and going into the serosa, which is the outer layer of the colon, and it has involvement of some lymph nodes, surrounding lymph nodes surrounding lymph nodes of the colon. Stage 4 is when, unfortunately, the cancer has gone to other areas. These areas could be the liver, the lungs, the rest of the belly, the mentum, which is a fatty tissue surrounding the colon. Now, stage 1, you cure with surgery. More than 90% of patients, they get surgery done. Now, if you ask me in 12 years, 15 years, if I have seen a patient complicated with stage 1 colon cancer, no. These patients, they get cured. And on paper, yes, they may reoccur. Maybe you have seen a couple of cases in which it came back just because there was a positive margin at the time when they resected the tumor, and the patient lost the follow-up, didn't follow up with the surgeon or with the GI oncologist, with the gastroenterologist that did the procedure. These patients do extremely well, stage 1. Many times I don't see the patients because they are stage 1, they get cured by surgery, that's it. Stage 2 patients, the great majority of patients, they get cured. We're talking about raw numbers anywhere from 80–85%. They have a great prognosis. The cancer has not gone into the lymph nodes. However, those patients, depending on certain nuances of the staging, some of them might need chemotherapy, short course of chemotherapy, 3 months of FOLFOX or CAPOX, to decrease the risk of the cancer coming back. Most of the patients, I do not recommend chemotherapy for stage 2. But some of them I do. For example, if a patient had a tumor that it was a little bit on the larger size, or if under the microscope they looked that they were growing aggressively, like poorly differentiated carcinoma cases, patients whose markers in the blood, protein in the blood, are high, we know that those patients have a higher mortality if we don't treat them. Patients that maybe during surgery, no more than 10 lymph nodes were removed, because then I don't know what are those lymph nodes doing. And so those patients have poor survival if we don't treat them. But if they have more than 10 lymph nodes removed and they are all clear, then that's good. Then that's a patient that would not need therapy. Stage 3, as it is right now, today, 2024, March 14, all of them require adjuvant chemotherapy, anywhere from 3 to 6 months of adjuvant chemotherapy. We're trying very hard to limit the toxicity from the chemotherapy that we give. Before, when I started my career in oncology, I would always give 6 months of adjuvant chemotherapy to a patient with stage 3 colon cancer, always. But as of 2018, there was a new trial that showed that perhaps in selected patients, we could drop it to 3 months and we have the same outcomes. Still, the majority of patients with stage 3, they get cured. But many of them all of them require chemotherapy. Stage 4 is when the tumor has gone to other places, and our goal is to improve the survival, stop the cancer from growing, preserve an excellent quality of life. It used to be when I was in training that these patients would never be cured, stage 4. However, now we know that with the help of our colleagues in surgery, for example, a patient with limited metastatic disease to the liver with potentially chemotherapy and surgery of the liver, they may get cured. It's still a low rate, but now there is some light at the end of the tunnel for some patients with stage 4. Same as 8 to 10% of patients with colon cancer who will respond to immunotherapy. Some of them, it's too early to talk about cure, but we're seeing patients living 7 years, 10 years with no cancer, stage 4 disease. And that was unheard of 8 years ago, completely unheard of. But now we have patients living beyond the 5-year mark without any evidence of cancer. Some of us think that maybe these patients are cured for all intent and purposes. If they, for example, if they die from something else, and they were 70 at the time of the diagnosis. So these are exciting times. Now, I'm going to spend the last 3 minutes to talk about 2 new technologies. One technology is in the diagnosis, prognosis side of things, and the other technology is in the treatment side of things. The first one is circulating tumor DNA. Before, we used just to measure a protein produced by the tumor to see maybe the cancer would come back or not. That test is called CEA level. It's not good enough. We need it better. Now we have circulating tumor DNA. So now what we do is we take a piece of the cancer, of the particular patient's cancer, we analyze for the mutations, personalized to that specific patient. We literally take the tumor and it's gone to a company to analyze that mutation. And then a blood test is created to measure those same proteins that are in the tumor, those same DNA sequences, we measure in the blood. And we now are able to tell at the micromolecular level whether the patient has cancer or not, whether the patient is going to reoccur or not. And this is something called a Kaplan-Meier curve. The way to interpret this slide is as follows. This axis shows you the months, and this is the probability that the patient is not going to have cancer. If, let's go to B. If a patient has a blood test showing that at the 12-week mark after surgery, there is no cancer in the blood, more than 95% of them, whether they get chemo or not, they're gonna survive, they are cured. So this test is telling us that the patient might be cancer-free, we don't need to wait 5-year mark. This data is still too early, but it's very promising. Now, in patients who have that test positive in the blood, if they are ctDNA positive, this is what we see. With chemotherapy, we are able to salvage approximately 65%, 65% of those patients. There's not going to be evidence of cancer coming back 1 or 2 year mark. But the patients that they don't get chemotherapy and they are ctDNA positive, all of them, they're going to very rapidly, 6 to 9, less than 12 months, the cancer is going to come back. So this test is allowing us to select the patients whom we are going to give chemotherapy or not in the stage 2, and also whether the patient is going to have a great survival or not. This is too early, but in stage 2, there is enough data that we're implementing in clinical practice. In stage 3, we're going to open a trial here in Memorial to try and avoid chemo in some patients and to better tailor chemotherapy to patients with stage 3 disease. So now, going back to the therapy that our patient got at the beginning of the presentation, this patient got immunotherapy. In immunotherapy, what you do is you give a patient a medicine through the vein, and that medicine is going to stimulate the T cells, which are part of the immune system of the patient, to connect with tumoral cells. And when there is a connection between these two proteins called PD-1 and PD-L1, the tumor cells are destroyed, only the tumor cells, thanks to the immunotherapy medicine. The drawback is that some patients will have inflammation of other organs, liver, thyroid, colon, but only in small percentage of cases, 15%, and there is an antidote for those side effects, very easy antidote. And the upside is that these patients have excellent response to the treatment. Another drawback is that it only works so far in 8 to 10% of patients with colon cancer, some patients that have a specific mutation in some DNA repair genes. But the holy grail of colon cancer right now is to make that work in all of our patients. Now, this final graph shows you each line represents a patient, and this is where we start, and 100% below the line means that those patients, that particular patient, the tumor was eliminated with immunotherapy. So as you can see, in more than 90% of patients that got this immunotherapy with that specific mutation, the tumor was eliminated before surgery. And again, this is too early. It's only in 10% of patients that this works, but this is what our patient had, the immunotherapy, and he did great. So there are some changes, some differences of risk, as we discussed before, in race and ethnicity for colon cancer. And we really need to improve the screening, because if somebody doesn't have insurance, that person is not going to be screened. Okay, so it's 22 minutes. Thank you for your attention, and looking forward to your questions. And Dr. Herline.
Yes, thank you, Dr. Fabregas. If anyone does have questions for Dr. Fabregas, please hold them for after Dr. Herline's presentation, and then you guys will be free to ask them both questions. And Dr. Herline, you have the floor.
Thank you. Jesus, if you can stop sharing, then I will grab the screen. Thank you. All right. Are y'all seeing me okay?
Yes, Dr. Herline, we do see the upcoming slides on the left, not just the slide that you want to share.
Okay, hold on one second. See if I can get that back. Better?
Not yet, no. I think when you do different sides, if you have dual screens, sometimes that happens.
Okay, let me see what I can do here. Just a second. All right. Any better there or not?
No, but
It's
if
the
you
same. Maybe if you go to the slideshow tab, you'll be able to change it to presenter view.
I'm sorry, say that again.
Maybe
the
if you try the slideshow tab.
Y'all are talking over each other. Hold on one second. I
Oh,
apologize.
yeah, we are.
Sorry about it. Go right ahead. I'm listening.
Maybe if you try the slideshow tab at the top of your screen, you will probably be able to put it into the presenter view for us.
Slideshow tab on the
next to animations at the top of the screen.
Okay, I put it into slideshow. Let's see here. One second. I'm sorry, guys. I apologize.
That's all right.
No. Oh, if you know how to do it, please come in. It is on slideshow. Yeah, it's on slideshow tab. That's not the problem. I apologize. Let me see here. Give me 1 second. Any better?
Perfect.
Perfect.
Yes, that's perfect.
No,
Yes.
it took too long. I apologize. All righty. I'm Alan Herline. As Victoria was kind enough to say earlier, I run our colorectal cancer program, and I'm going to discuss some about treatment. I'm going to discuss screening again because I think it's so important, and I just appreciate Gilda's Club being willing to have myself and Jesus come and talk to y'all today. Again, we take care of a great deal of patients with these problems and just want to see colon cancer as something that is treatable, it is preventable, and it is beatable, and that's the way we want to approach this. I'm from North Georgia originally. I spent most of my career at Vanderbilt in Nashville, and I really am here to elevate and leave memorial in how we care for colon and rectal surgery. My door stays figuratively and literally open for any kind of suggestions. One of the things that one of my mentors used to say is we make calculated risk. The patient takes all the risk. We make all the calculations as physicians. And so when we talk about treatment or screening or anything like that, we realize that y'all are willing to put your lives in our hands, and we take that very seriously. But I have fun with my job too. It's a glamour field. You're seeing half of my clinic right there. What are the symptoms of colon cancer? If nobody hears anything else today on this talk, I want you to hear this. The number one symptom of colon cancer is, oh wait, maybe the screen broke. Hold on. None. No symptoms. There are no symptoms with colon cancer in the majority of people. So when patients or friends tell you, oh, I'm not having any symptoms, it does not matter. Wave them off completely. Nothing is the most common symptom that goes along with colon cancer. And so that is why we need to get screened based on many of the things that Dr. Fabregas already presented, and not based on just a feeling of whether I have a cancer or don't have a cancer. There'll be over 104,000 new cases of colon cancer, over 45,000 new cases of rectal cancer, and screening still lags behind. Colon cancer screening still lags well behind breast cancer screening and mammography. In 2016, the screening rate for colon cancer was about 65 to 67%. And sadly, the rate among 50 to 64-year-olds who are the most at risk was only in the 50s. And that's up from 2012. So we can and should do better. What does that mean? How do we translate that here in Florida? That means there's 2.3 million Floridians that are in need of screening. And that's possible 100,000 cases of unresectable polyps and or cancer that is sitting out there with patients that are just unaware. So we can go through the epidemiology. We can go through all the statistics. It is worldwide responsible for over 650,000 deaths every year. So why screen? We screen because it's an effective way to save lives. We screen because it can keep people from developing colon cancer and can allow people to continue to live healthy lives. So what does that mean? I'm sure people wonder all the time. If you look over the screen on the right, you see a normal colon up in the top part. You see a small tiny polyp in the next slide. The next slide down from that, you see a slightly larger polyp. And then what you see is what can happen with screening colonoscopy, where a polyp is removed and then no longer will develop into the cancer that you see on the bottom right of the screen. That is our goal. That is why we do screening, so that you don't have to have the great skills of Dr. Fabregas. You don't need to have that done. You don't need my skills in the operating room. We can screen you and take care of this before cancer develops. Colonoscopy is considered the gold standard. All other tests are compared to colonoscopy and its ability to remove polyps and to find cancers. So as we talk about new screening tools, realize those screening tools are never better. They all have false positives and false negatives. And so therefore, we still recommend colonoscopy as the number one screening tool that's out there. These are the estimated deaths in the U.S. from colon cancer, and you'll see that number 3 on the list for men and women is colon and rectal cancer. Remember, everybody poops. So that's important to know. And part of the prep for the colonoscopy is making sure you poop a lot so your colon's clear so we can see what we need to do with you next. All right, let's talk about colon cancer in the young. Dr. Fabregas touched on this, but ages 20 to 34 by 2030. So that's not too far from now. 6 years, there will be a 90% increase in colon cancer and 124% increase in rectal cancer. So you say, well, gosh, if we're not screening till age 45, how would we come about finding that out? Well, a lot of how we would find that out is by screening the mothers, the fathers, the brothers, and the sisters as they get to age 45 and therefore working backwards. So we can continue to do a really good job of eliminating colon cancer by being more aggressive with our screening for patients that are having problems. How much can you affect this? Well, you affect it first and foremost by doing a colonoscopy if you're of age 45, or if you're high risk, like Dr. Fabregas was saying, 10 years earlier than the youngest family member that had a colon or rectal cancer in your family. Are there environmental factors? Being male will absolutely increases slightly your risk. Age and time increases your risk. Obesity, and then genetic susceptibility. I often get asked about diets that are high in fat, low in fiber, higher in red meat. All of those things listed there can end up increasing your risk for colon and rectal cancer. Dr. Fabregas went over the stages here. I'm putting them up there. In general, stage 1 at 90% survival, stage 2 at 80% survival, stage 3, 60 to 70% survival. In the world of cancer, these are really good numbers. So there's really good reason to get screened, because even if you do have a cancer, far and away the majority of the time, we are going to be able to offer you a cure. As Dr. Fabregas was saying, with many of the new studies coming out and new drugs, we have an opportunity, even for patients with stage 4, to offer much better outcomes than ever before. All right, so surgical resection, what's involved? I have part of my colon that has a cancer in it or a large polyp. What are they going to do? First of all, I get asked all the time, how much of my colon are you going to take out? And I have two answers to that. The first one is, it does not matter. Meaning your body will adjust regardless of how much colon we take out. I can take out nearly your entire colon and your quality of life will return back to normal within about 3 to 4 months. So it doesn't matter. The second thing is, we take out the amount of colon we take out to make sure that we find enough lymph nodes so we can make a decision, by we, meaning myself and Dr. Fabregas, can make a decision on whether you need additional treatments. So for a right colon, if you can see the shaded area there, including your appendix, your right colon would come out and take that part of the section. If instead you had a left colon cancer, I'm sorry, it looks like I'm missing that. I apologize. If you had a left colon cancer, then we would take out a similar mirror image of that on the left side. What does colon resection involve? Standard colon resection involved a midline incision, where we would explore then inside the belly. We would do a resection like I just talked about, where we make sure we got all the lymph nodes. You would start up a diet post-op day or after your operation 3 or 4 days later. You'd finally be discharged home, the national average around 8 to 9 or 10 days. You'd have narcotics for pain for about 4 weeks, and hopefully could return back to your normal lifestyle or work within 6 to 8 weeks. That is what we used to do, and that's still where a lot of institutions are in terms of their care for colon cancer. The other problem with this is, if you have a cancer that then needs chemotherapy, you are delayed in getting your chemotherapy because of these approaches. So how do we do it? We do far and away the majority of our cases here at Memorial in the Memorial Colorectal Surgery Program with either robotic or laparoscopic, and with ERAS, which is Enhanced Recovery After Surgery. So this is how we do this. What does this mean? That means we use small incisions for doing the same operation. It involves the use of trocars, which are like tubes. They go inside your belly. We fill your belly with CO2, and we do the entire operation through that while we're looking up on a screen. The screen actually magnifies our view, and so we're actually able to see in more detail than we would be with a standard operation. After that, and because of the way we give our anesthesia, patients are able to spend less time in the hospital, less recovery time, less scarring, and less pain. So what do we tell patients? I tell patients, when you wake up from your operation, you'll be able to take clear liquids. As soon as you are taking clear liquids and you start passing gas or having bowel movements, we'll give you a little food. As soon as you've had a little bit of food, you're drinking enough to keep yourself hydrated, and you're passing gas or having bowel movements, you can go home. Our average length of stay is 2 or 3 days. And for most of our patients, or for about 30% of our patients, they will go home actually in 1 day. So that is, if you find yourself in that position, yourself, a loved one, a family member, the surgeon that takes care of them ought to be able to discuss in great details, not just what he or she does technically, but also what the anesthesia team does and how they provide the best possible care for the patient. All righty. So this is our new nurse practitioner that you can see there. He's quite forceful about making sure everybody gets their colonoscopy done. Make sure that you pass all of your anal exams that are coming up. And perspective is really important. Get screened for colonoscopy. Make sure you get that done. Let us know how we can help in any way possible.